This is Claude Yancey at the 2011 American College of Cardiology meeting discussing the late-breaking clinical trials for the segment on theheart.org called Trials in PI. I am delighted that one of the PIs who's joined us for our discussion is in fact my friend and colleague at Northwestern, Bob Bonow. Bob, welcome.
Thank you, Clyde. Happy to be here.
I'm happy to have you here, particularly to discuss the information from the STITCH trial as it pertains to myocardial viability. Just to set this up for our audience, primarily we all would think that if there's evidence of viability, that ought to be the group that benefits the most from revascularization, but it needs to be tested. And in a very fortuitous way, it was evaluated as part of the STITCH trial. So let's really hone in on the viability, the different ways that we looked at viability, who was incorporated in STITCH, and what did we see?
Yeah, well, I think you're right. This was a optimal time to finally do a prospective trial, because all of the data we base our knowledge on has been retrospective. Much of it comes from the 1990s, before people were giving aggressive medical therapy. In fact, in some of the cohort studies, there's no mention of even what the medical therapy was. And we do know that with aggressive medical therapy, viable myocardium also improves from beta blockers. And so there's kind of equipoise as to whether surgery benefits people with viable myocardium over medical therapy. And that's why we kind of got into this with STITCH. Now, we had, a large trial. It was international. We couldn't do MRIs in everybody, and it was funded by the NHLBI. We had enough money to do the trial, but not elaborately so. And so we had to limit this to the kind of tests that would be widely available internationally. So we used SPECT, perfusion imaging, and dobutamine echo. And luckily, there are previous data from these previous studies we talked about that are retrospective, telling us that these are the tools one could use to predict not only improvement in function, but also survival. And so we use those pretty well standard tests that are widely available. And that's how we got into using SPECT and dobutamine echo, not PET, not MRI.
But the one thing that's really good about that is that it's very much a real-world study. These are the strategies being used internationally to answer these questions, so the findings will be applicable. Now, we didn't do viability on everybody in STITCH, about half, is that correct?
Yeah, so the initial trial design was everybody.
Right.
And again, because of some of the funding issues and also regarding enrollment rates, we had to make it easier to get patients into the main body of the trial, which is really very important. Right. Does revascularization help or not? And therefore, we made it more optional. It was not a prerequisite for enrollment. So, but about 50%, 601 out of 1212 patients had a viability test.
And do you think that 600 was representative of the overall population?
Well, not quite, not quite. It was interesting, actually, because the patients who had a viability test versus those who did not were sicker patients. It was like the physicians were using this information maybe to help guide them a little bit more. Now, we don't know what was going on because we only look at the patients who actually got enrolled. We don't know if patients were not enrolled in STITCH because of other tests.
That's a good point.
That we'll never see. Yeah. But the patients who had a viability test were sicker patients with more prior MIs, more heart failure symptoms, receiving more evidence-based therapies, more ACE inhibitors, beta blockers, had lower ejection fractions and higher end diastolic and systolic volumes than the patients who did not get a viability test. So our findings, therefore, are not necessarily representative of the entire group, because the other patients who were not studied maybe were less sick. And there may have been other things in those patients which were viability testing might have given us a different answer, but we don't have those data.
But regardless, we did see some interesting findings in the viability studies. So let's kind of go through that because it does inform us more than we've had before.
Yeah. Well, I think viability testing does matter. I wouldn't say that our tests, our results are entirely negative. The patients who had myocardial viability had a better survival than the patients without viability, and they also had a better, lower mortality and or hospitalization when we looked at a combined secondary endpoint.
I wouldn't even be tentative. I would say that absolutely viability does matter. And so as a clinician who's looking at these patients with reduced LV function, multivessel coronary disease, and some component of heart failure, when the viability is present, we need to know that because it does inform our clinical judgment.
Absolutely. Now, given the fact that the patients who have viable myocardium are also different patient population than those without viable myocardium, there's some other co-founders here that then, when you do a multivariable analysis, that important signal from viability becomes less important. In fact, it became insignificant for us because the patients who had no viable myocardium also were patients who had more risk. They had more previous MIs, they had lower ejection fractions, and also bigger ventricles. And so when you started doing a multivariable analysis, the viability signal factored out more or less. It was no longer significant. It still was significant for death plus hospitalization, which is used in many heart failure trials, as you know, as an important endpoint. But our primary endpoint of survival was not significantly influenced by having viability or not. And then we looked at the interaction of viability and what treatment the patients got, cabbage versus medical therapy.
So it does appear, though, that what trumps everything is the degree to which you have heart failure.
Yeah.
Because if you've got lots of scarred tissue, if you've got a very low EF, that really does drive your outcomes. And even though it's not necessarily a new message, it's an important message to emphasize, particularly in this kind of study, where everything is predicated on ischemic heart disease. So I think we really understand a lot more about managing patients with ischemic heart disease and heart failure now than ever before.
Yeah, and I think that's a very important point, because the medical therapy group actually did quite well, and better than some of those other retrospective studies I talked about before, where the survival of medical therapy was not good, and maybe the results there would be considered in current terms unacceptable, because they were not receiving evidence-based aggressive medical therapy. And in our study they were. That's why I think the curves kind of narrowed in terms of outcome with cabbage versus medical therapy. They were quite well treated.
So as we wrap this up, we visited with Dr. Velasquez, and when we talked about take-home messages, a couple of take-home messages that we articulated was that, one, medical therapy is a very reasonable treatment strategy when done correctly for patients with reduced EF and multivessel coronary disease. As well, surgical treatment is appropriate for selected cases that is a function of their operative risk or a function of the ability to completely revascularize patients. So we shouldn't look at the stitch data and say surgery is not a reasonable option. I think to those take-home messages, there's some more that you can add about viability, and I'll let you kind of finish that up for us.
I think one of the important points is all these patients have viable myocardium. They're alive and they have hearts that beat. And so there's this continuum of how much is alive or not. It may be the patients who've got the minimal viability, who have got hanging on by a thread. They're not going to survive their next MI. Revascularizing those patients may be important. So I wouldn't hold back cabbage because of a negative viability test. If I had a 60-year-old patient, multivessel disease, good distal targets, I'd revascularize the patient without a viability test. Now, on the other hand, if I had an 85-year-old person who's got heart failure, prior cabbage, poor distal targets, diabetes, and renal insufficiency, I might want other information, like a viability test or something else to help me determine whether this person is a good candidate or not. So you have to use these tests selectively. I
like those scenarios because I think that's the take-home message better than anything we can articulate. I'm delighted that Dr. Bonow has been with us today in Trials and PIs discussing the viability component of the stitch results that were released here at the 2011 ACC meeting. This is Clyde Yancey, hoping that you've received some valuable information from what we've discussed today. Thanks very much, Bob.
Thank you, Clyde. We're done.
All righty.
Your wrap-up is so smooth. I mean,